So today we are going to discuss about stroke or cerebrovascular accident CVA. It is a sudden onset of characteristic neurological deficit which is caused by interruption of blood flow to brain. It results in distinctive neurological signs which usually reflect the region of brain which is involved. According to WHO, the stroke is defined as neurological deficit of cerebrovascular cause that persists beyond 24 hours or is interrupted by death within 24 hours. So in this definition we are saying 24 hours because if it resolves within 24 hours it will be considered as TIA and not the stroke. Now if we see the statistics, stroke is the second leading cause of death worldwide and is ranked after heart disease and before cancer. Patients who experience stroke often have history of hypertension, diabetes mellitus, valvular heart disease or atherosclerosis. So now we discuss about the type of the stroke. So it is divided into two types, that is ischemic and hemorrhagic. Now let's discuss the important differences between these two types. So in ischemic stroke there will be ischemia or infarction, whereas in hemorrhagic type there will be hemorrhagic disruption, or we can say bleeding in brain tissue or subarachnoid space. Ischemic type is more common, comprising of 80% cases, whereas hemorrhagic is seen in only 20%. Ischemic stroke may be occurring due to occlusion or embolization or decreased cerebral perfusion. Now coming to occlusion, the most important cause is thrombus, which usually forms around the atherosclerotic plaque. This thrombus, it may block large vessel or branch vessel or small perforating vessels. In case if it blocks the perforating vessel, it will result in lacunar infarct. Then coming to embolization, here the emboli will block the vessel. These emboli, they may come from thrombus if it dislodges from atherosclerotic plaque, or they may come from heart or from other possible sources like in the form of air emboli, fat emboli or tumor emboli. In case of hemorrhagic stroke, it may be caused by hypertension, aneurysms, arteriovenous malformations, coagulation disorders, anticoagulant therapy, trauma or drug abuse like for example cocaine. Now hemorrhagic stroke, it is of two types, that is intracerebral hemorrhage or subarachnoid hemorrhage. In case of intracerebral hemorrhage, bleeding occurs within the brain tissue itself, whereas in case of subarachnoid hemorrhage, bleeding occurs outside the brain tissue. If we say precisely, it is between arachnoid and pia mater. Now let's discuss about signs and symptoms. So they basically depend on arterial territory which is involved. So first discuss about anterior circulation or carotid circulation. In carotid circulation, let's begin with anterior cerebral artery. So if this artery is blocked proximal to anterior communicating artery, usually the person don't develop any signs or symptoms, as the blood flow is compensated from collateral circulation. But in case if the blockage is distal or if the blockage is distal to anterior communicating artery, then the person will develop weakness and cortical sensory loss in the contralateral lower limb. The person will also develop urinary incontinence, contralateral grasp reflex, abulia. So abulia is a Greek word meaning lack of will. So in this condition, the person lacks motivation or initiative, or we can say he cannot take independent decisions. Then the person may develop apraxia. Here the person face difficulty with motor planning to perform normal routine tasks or movements. For example, as you see in the image here, the person is trying to comb the hair while he is holding it reverse. In some other cases, they may try to comb the hair with toothbrush, or they may wear the shoes before wearing the socks, and so on. So there are many such examples of apraxias, which is beyond the scope of this lecture. So now let's come back to topic. So another rare feature of anterior cerebellar artery occlusion is cerebral paraplegia. This problem occurs in rare cases where the occlusion is proximal to anterior communicating artery and both anterior cerebral arteries arise from the same site. Now next, coming to middle cerebral artery occlusion. Here the person develops contralateral hemiplegia, contralateral hemianesthesia, contralateral homonymous hemianopia. For example, in case of homonymous hemianopia, the person will be able to see the objects on his particular one side and another half of the visual field will be blank. Like for example, in case of right homonymous hemianopia, the person will be able to see objects on his left side while blind to the objects on his right side. Then the person will be having Wernicke's aphasia or fluent aphasia, or we can say receptive aphasia, in case if the dominant hemisphere is affected. So here the patient, in case of Wernicke's aphasia, we can say the patient talks too much and does not understand what others are saying, and others don't understand what patient is saying, and we can say the patient himself don't know what he is talking. So that's the Wernicke's aphasia. Sometimes the person develops neglect of contralateral limbs and dressing difficulty if in case non-dominant hemisphere is affected. And the eyes of the person will be deviated to the side of the lesion. Now let's come to posterior circulation or vertebrobasilar circulation. So here let's begin with posterior cerebral artery. So with occlusion of this artery, the person will develop midbrain syndrome. It is also known as Weber's syndrome. This condition is manifested as third cranial nerve palsy together with contralateral hemiplegia. Then the person will develop thalamic syndrome, which is manifested as chorea or hemibalismus together with hemisensory disturbance. Then the person will have macular sparing homonymous hemianopia, prosopagnosia, memory defect, and dyslexia without agraphia. Next, come to occlusion of paramedian branches of basilar artery. Here, the person will develop contralateral hemiplegia, contralateral sensory loss, ipsilateral cranial nerve palsy at the level of lesion, and sometimes locked-in syndrome in case if there is bilateral damage at pontomedullary level. So in this condition, the patients develop acute hemiparesis, which rapidly progress to tetraplegia and lower bulbar paralysis, involving 5th to 12th cranial nerves. So initially the patient is dysarthric and dysphonic, but rapidly he progresses to mutism. But we can say the consciousness and sensations are preserved. So in locked-in syndrome, the person or the patient cannot move or speak, but he remains alert and oriented. And horizontal eye movements are impaired, but vertical eye movements and blinking remain intact. So communication can be established via these eye movements. Now let's come to bilateral vertebral or basilar artery occlusion. In this case, the person will be in coma with pinpoint pupils, flaccid quadriplegia, and sensory loss along with variable cranial nerve palsies. Now coming to cerebellar arteries, it is important to remember that occlusion of any major cerebellar artery will result in vertigo, nausea, vomiting, nystagmus, ipsilateral limb ataxia, and contralateral spinothalamic sensory loss in limbs. So now let's briefly discuss signs and symptoms of individual cerebellar artery occlusion. So first begin with posterior inferior cerebellar artery, also called as pica. So if this artery is occluded, the person will have ipsilateral spinothalamic sensory loss in face, ipsilateral 9th and 10th cranial nerve lesion, ipsilateral limb ataxia, ipsilateral Horner syndrome, and contralateral spinothalamic loss in the limbs and trunk. So here other features like ipsilateral limb ataxia, ipsilateral Horner syndrome, and contralateral spinothalamic sensory loss in the limbs and trunk, they are common. So only important one to remember is 9th and 10th cranial nerve lesion. Then coming to anterior inferior cerebellar artery, here the person will develop ipsilateral spinothalamic sensory loss in face, ipsilateral facial weakness and deafness, ipsilateral limb ataxia, ipsilateral Horner syndrome, and contralateral spinothalamic sensory loss in limbs and trunk. Here also the last three features are common. So only important feature to remember is ipsilateral facial weakness and deafness. Now coming to superior cerebellar artery, the person will develop ipsilateral limb ataxia, ipsilateral Horner syndrome, and contralateral spinothalamic sensory loss in limbs, trunk as well as face. So here also the only important point to remember is contralateral spinothalamic sensory loss in face along with limbs and trunk. Now I am finishing my today's lecture with a note that if the hemiplegia is of pontine origin, the eyes will point towards paralyzed side, whereas in case of hemispheric lesion, the eyes they will deviate away from the hemiplegic side. So that's all for today. I will continue remaining part of this topic like investigations, management, etc. in next lecture. So thank you. Have a nice day.